Good morning and good afternoon, everyone. My name is John Brogan. I'm a WASH advisor with Helvetas, and I'm also part of the consortium management unit for this third phase. And I'm very happy to be presenting to you today about definitions of indicators for monitoring WASH in healthcare facilities in our third phase. As you know, WASH in healthcare facilities has now become a global focus among our community of practice for WASH. And so I'm excited to see where our WASH in healthcare facilities projects are going to take that community of practice in terms of learning and thinking. Our base is the joint monitoring program of WHO and UNICEF in the Sustainable Development Goal monitoring framework, their laddered approach to different levels of service. They have included guidelines on WASH in healthcare facilities for 5 different kinds of services. You see water, sanitation, hand hygiene, as well as healthcare waste management and environmental cleaning. So here, what's important to note is that these targets and monitoring definitions of the JMP are the same as our outcome indicators for WASH in healthcare facilities. We're aiming at this level of basic services in each of the 5 categories. There may be instances where a project team is working on a specific service and they're not able to achieve the basic level, but they may go from no service to limited service. This is still progress, and this is still something that we will capture in our monitoring system, in our monitoring tools. Speaking about our monitoring tools, I'm sure by now you've heard of FACET, the Facility Evaluation Tool for WASH in Institutions. This has a module both for schools and for healthcare facilities. And so this is how we're going to monitor WASH in healthcare facilities. When we should conduct the FACET survey, well, what we've decided is annually for outcome indicators on WASH in healthcare facilities, and every 6 months for the output indicators. There may be some more in-depth questions to do for baseline and endline surveys, but in short, the outcome indicators, there are relatively few. There are relatively few questions, and this kind of an annual level survey could be done quite easily. The output indicators that we'll be presenting for WASH in healthcare facilities will be filled in an online reporting system, and we'll be getting into more of those details in the weeks to come. About the question of when to conduct the FACET survey, if we're talking about in a day, it's important to know when there are peak patient flows in a healthcare facility, when the healthcare facility staff and resources might be needed more to attending to the patients. So we want to ensure a quality of service, and in that sense, get a feeling for when would be a good time to approach the healthcare facility staff about doing a survey and what times you should avoid. In terms of who to involve, it's highly recommended to have someone from the healthcare facility management staff or the in charge of the healthcare facility accompany you when you do the survey. If possible, also municipal and district authorities can accompany you. In terms of who should be informed about the results, well, definitely share the results with the healthcare facility management committee. Also look to share with the municipal health authorities or with the district and regional health authorities. And there can even be an option to share what's happening on the ground with national level working groups on WASH in healthcare facilities. Just like to make the distinction between FACET and WASHFit. FACET is our punctual monitoring tool. It is mobile data collection based and it's online. We also have WASHFit, which is the facility improvement tool. Far from a monitoring tool, this is a methodology. This is what we use on a day-to-day, week-to-week basis when we're interacting with the management committee of a healthcare facility and the healthcare facility staff. So this is a participative risk analysis and improvement monitoring tool which promotes continuous quality improvement within healthcare facilities. And this is our tool of choice for the day-to-day, week-to-week implementation in the third phase of the consortium. One change between the second and third phase involves how we're counting the beneficiaries for WASH in healthcare facilities. We're not counting all of the residents of a locality around the healthcare facility, because this doesn't reflect the reality. Not all of the catchment population is using the healthcare facility. We are not counting the number of patients, because patients is individuals, but also these individuals could visit multiple times. So we decided on a more scientific, if you will, calculation where we're basing it on a scientific reference. And it is the number of persons who are receiving services in a healthcare facility at least once in the life of the project. And how we're calculating this, it's, well, many project teams have already done this calculation in creating the project document, but if there are project teams who haven't yet used this calculation, please contact your regional advisor or contact me and we can support you to make this calculation. It's basically in the last 12 months in a given healthcare facility, how many patient visits were there? And you add all of the different healthcare facilities for those 12 months and you come out with a large number of the total number of patients in the previous 12 months, or it could also be in the previous calendar year that have received treatment, and you divide it by a factor. And this factor is provided by a scientific journal article in the Lancet, a journal review. And the factor varies by country, but it's basically saying the average number of times a person who does seek treatment will do that in a given year in a given location. So with that, we will come to the reference material that the consortium has put together on the definition of indicators for Washington healthcare facilities. We've already gone through a lot of these general comments about service ladder, about the frequency of reporting, about the online system, and about FACET. But like I said earlier, in the webinar to come, we can address more specific questions and give you more specific information about that. We've also talked about how we'll be collecting data on Washington healthcare facilities and calculating the number of beneficiaries. So now we're getting into the key indicators at the outcome level. Again, these are the basic level indicators, definitions that we saw from the JMP document. For basic drinking water service, we want to look at the aspects where the main source of water is an improved source, it's located on the premises of the healthcare facility, and water is available at the time of the survey. So this is referring to water for general purposes, drinking, washing, cleaning. And when we talk about on premises, we're really talking about within the building or on the facility grounds. And that water has to be available at the time of the survey. There are a few different types of improved sources which qualify, and you can see those also listed here in the definitions. There are two additional indicators which go beyond the basic level service, and they look at the functioning of the water facilities, as well as the quality of water, whether or not it's safe to drink. So here, we could call them advanced level indicators, but since advanced level indicators are defined at the level of the country, we feel that these two indicators would lend weight to the substance of our Washington healthcare facility intervention. So about the functionality, here we're looking at it's a functional improved source, and there's a dedicated budget for operation and maintenance. And to measure this, we'll be looking at the last 6 months. So in the last 6 months, the system may have had a breakdown. It may have stopped working, or the amount of water it's producing may be less than half of what it was designed for. If either of those occurrences come to be, then the measure should be were they repaired and were they repaired within a week. So this is an indicator which can be asked to healthcare facility management staff, ask them to recall in the last 6 months, when it broke down or when it wasn't providing enough water, was it repaired within a week? The second indicator is about access to what would be considered by WHO definitions as water which is safe to drink from the microbiological standpoint. So here we're looking at the source would be the main drinking water storage container. If there is no storage container from which to take a sample, then people are consuming directly from a water tap, then you would have to test the water at the water tap. Here, we're really looking for what is the national level indicator. That's our first reference. But in absence of a national level indicator, then the WHO has a full absence of E. coli, and that's the one that we should be shooting for, either with our broad tests, our kit tests like WAGTEC or Delagua, or with our presence and absence tests. And all of the guidelines for how the Swiss Water and Sanitation Consortium will be monitoring water quality are in the document, which has a hyperlink there, the Swiss Water and Sanitation Consortium Microbiological Water Quality Test Guidelines. Another aspect to monitor and measure in the healthcare facility water quality environment is the presence of residual chlorine. So for those healthcare facilities that are treating water with chlorine, the teams should work with the staff to be able to test those levels. So at least once a year, this kind of testing should take place, and where possible, the staff themselves should perform the test with a simple pool tester. In these times of COVID, with outbreak situation or of cholera and so on and so forth, the minimum residual level of chlorine in the water should be 0.5 milligrams per liter. In other times, it can be 0.2 milligrams per liter. But in a healthcare facility in this day and age, it's probably best to look for 0.5 milligrams per liter. Coming to sanitation, this basic level of sanitation service is, it has a certain degree of complexity to it. It's not always easy to get across the finish line of achieving basic level of sanitation service in a healthcare facility. So let's break down the language which is used in this indicator. Here we're looking at the healthcare facilities that have improved and usable sanitation facilities, at least one toilet dedicated for the staff, at least one sex-separated toilet with menstrual hygiene management facilities, and at least one toilet which is accessible for people with limited mobility. So here, improved sources, as we know, are hygienically separating the excreta from the environment. And to be considered usable, a toilet should be available, it should be functional, and it should have measures for privacy at the time of the survey. So this is all observation. So where there are multiple toilets, please observe the most common type of toilet which is used by the patients. We're talking about availability. It means the patient should be able to access the toilet. The door should be unlocked, or if it is locked, there should be a key which is available for those patients. For functionality, the hole or the pit should not be blocked. There should be no cracks or leaks in the toilet structure. For privacy, there should be a locking mechanism inside so that the door can lock from the inside. And there should be no obvious gaps or holes in the superstructure, in the walls. Toilets that are dedicated for staff should be for the exclusive use of staff. And here when we talk about at least one sex-separated toilet, you see toilets could be in a toilet block with multiple toilets inside. And if this is the case, at least one of those toilets should be dedicated for women. And it should be marked for women use only. In cases of smaller healthcare facilities, as is common in many of our project areas, there may only be one toilet in the whole facility for patients. It doesn't mean that it won't make the sex-separated aspect of this indicator. You can have a gender-neutral room that both men and women can access, but the important is that it allows women and men to use the toilet separately, and that the toilet doesn't necessarily need to be women only. Menstrual hygiene management facilities include a bin with a lid on it for safe disposal of menstrual hygiene materials, as well as water and soap available within the toilet so that women have access for private washing. Limited mobility, I would say the first thing to look at is national standards and to respect those national standards when you're constructing toilets for people with limited mobility. In absence of that, these definitions provide 4 or 5 points to take into consideration. Coming to hygiene, the main thing with hygiene is that there is a functional hand hygiene facility. It's available at points of care and also within 5 meters of the toilets in the healthcare facilities. So functional hand hygiene facilities mean that they have water and soap available, and in absence of soap and water, alcohol-based hand rub is okay for points of care. However, within 5 meters of a toilet, the hand hygiene facility should have both soap and water, as alcohol-based hand rub is not sufficient to remove fecal matter from the hand. When we're talking about points of care, these are consultation rooms, treatment rooms, anywhere where care is provided to a patient. In this case, the points of care should have hand hygiene facilities inside of them. Let's say that there's a hand hygiene facility just outside of the point of care, inside the hallway, for example. This wouldn't count. Any treatment room or consultation room should have a hand hygiene facility. It can be something like a sink with a tap and a soap facility. It could also be something very basic like a basin and a pan for pouring water. In places where there are multiple points of care, which will be common, you can select one at random and observe the situation in that point of care. Healthcare waste management is also a challenge to secure the basic level service. Here we're looking at waste being safely segregated into at least 3 bins for the different types of waste, and that sharps waste and infectious waste are safely treated and disposed of. When we're looking at the different types of waste, you have general waste, you have sharps waste, and you have infectious waste. So these 3 different types of wastes should be safely segregated at the place of treatment or consultation. And they should be the bins should be clearly labeled or color-coded. Now, in some places for sharps waste, they do have specific containers which are puncture-proof, but any disposal of sharps waste, if it's not in a specific container which is dedicated for safe disposal of the sharps, should make sure that it is puncture-proof. And bins should be appropriate to the type of waste that they're containing. In the event that you have multiple places of treatment and points of care, you can select one at random and observe the situation. When we're looking at options for safe treatment and disposal, we have a few options that are listed here. Autoclaving, so a device, a machine, which is raising temperature and pressure to sterilize equipment. It can also be used to sterilize waste. The waste could be incinerated if it is in a proper incinerator, 2-chambered, which is achieving 850 degrees Celsius, which is required for the proper incineration. It's important to note that open burning is not a quality indicator, or is not a criteria for the basic level indicator. In the case that there are different methods for waste disposal, then the method which is most often used should be selected for evaluation. Environmental cleaning. Here we're looking at the existence of cleaning protocols at the healthcare facility and whether the cleaning staff have been provided with training to implement cleaning. So these men and women who are assuring the cleaning of the healthcare facility are really on the front lines of everything which is safeguarding the health and well-being of patients and staff inside of a healthcare facility. They are the true champions of infection prevention and control, and particular focus should be given to encouraging their participation and their leadership and their voice in different matters in the governance of the healthcare facility. So for this, at least they should have access to a cleaning protocol, which has step-by-step techniques for the specific tasks, such as cleaning floors, cleaning spills, cleaning sinks, toilets. And there should also be a cleaning roster, which specifies the responsibility for the cleaning tasks, who has it, and with what frequency, and also that it was properly performed. It's important to note that these protocols and different, how to say, the cleaning rosters, you know, there may be a certain number of these women and men who are cleaning who don't have a literacy ability to be able to use the typical written form. So in that case, we should come up with some other types of materials and types of interactive picture materials to be able to respond to their needs in understanding and fulfilling their duties. The staff responsible for cleaning, it could be anyone from auxiliary health providers, orderlies, auxiliary staff, and any staff in addition to their clinical responsibilities may also be involved in cleaning. So the wash infrastructure, coming to the outputs. These outputs are monitored on a 6-monthly basis. And for drinking water supply systems, we're looking at the number of locations within a healthcare facility where water points have been installed or rehabilitated. So let's say that a given healthcare facility has several wards or several rooms, and there's a water source or water tap in each of those rooms. We would count each of the taps, but we wouldn't count each of the faucets, if you will, or each of the individual taps within that water point. But each water point within a room or within a ward would be counted as a single water point and would be counted toward that indicator. Coming down to improved sanitation facilities, here we just want to know the number of facilities which have been constructed or rehabilitated. However, there are several levels of disaggregation. So broadly, we want to know how many facilities are for women only, how many facilities are gender neutral, how many facilities are for men only, in that case that they exist, and also sanitation facilities dedicated for staff. Those 4 categories, and the first 3 categories for women only, those sanitation facilities for women only that are also with menstrual hygiene facilities and or for people with limited mobility. And the same thing for sanitation facilities that are gender neutral. And sanitation facilities that are dedicated for men, those facilities which are accessible for people living with limited mobility. So this will be a selector that you can have in your periodic 6-monthly report and enter the data directly online. In terms of wash and other capacity, we talked about the environmental cleaning and training. So for training, we'd like to know the number of health professionals who are trained. This includes cleaners, regardless of the level of literacy that they have. So there could be 2 types of training, a basic level training for cleaning, and then a broader level of training for infection prevention and control. And here it's important to note that many countries have come out with infection prevention and control guidelines, as well as training modules, and they've trained master trainers. So where these guidelines and protocols exist for infection prevention and control, we should be using them. And where the trainers exist, we should also make an effort to involve them in our projects. In absence of one or both, we could use Teach Clean, which is developed by the Soapbox Collaborative, and it's a wonderful tool for introducing basic cleaning procedures and infection prevention and control training to healthcare cleaning staff. And finally, the number of people who are using WashFit. Again, this is our implementation methodology. So WashFit is the facility improvement tool. There are teams formed who are trained on WashFit and who participate as a team member. And so here, excuse me. Here we'd like to know how many people have been trained on WashFit and also how many people are part of the WashFit team. So these could be healthcare facility staff, they could be health authorities, locally elected officials, and or other community members. I appear to have lost my voice toward the end of this video. I'm very delighted to be working with you, and I look forward to our exchanges in the webinar. Preceding the webinar, we'd like to receive your questions about this presentation, about this document, or anything else you might want to look into with Washington Healthcare Facilities, and we'll see how to answer those during the webinar. Thank you very much, and have a wonderful day.